Good afternoon, everyone. I'm Philip Osteen, the Interim Dean of the University of Utah College of Social Work, and it is my distinct pleasure to welcome you to our Social Work Beyond the Classroom presentation. As the name of the series suggests, these presentations allow us to delve into the work that engages our faculty members outside of their teaching duties and provide learning opportunities for students, graduates, and others in the community. Before we get started, on behalf of the college work, I'm especially proud to recognize the heritage and contributions of our American Indian community members by acknowledging that this land, which is named for the Ute tribe, is the traditional ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. The University of Utah recognizes and respects the endearing relationships that exist between many indigenous peoples and their traditional homelands. We respect the sovereign relationship between tribes, states, and the federal government, and we affirm the University of Utah's commitment to a partnership with Native nations and urban Indian communities through research, education, and community outreach activities. Today, we're excited to showcase Dr. Christopher Cambron as he shares findings from multiple recent studies examining how socioeconomic disparities relate to tobacco use and cessation. Dr. Cambron is an assistant professor who joined the College of Social Work faculty in 2019 after a 2-year postdoctoral fellowship with the Huntsman Cancer Institute. He earned his PhD from the University of Washington and his master's degree in social work and public policy from the University of Utah. His research focuses on approaches to understanding connections between macro-level social determinants of health, meso-level social processes, and micro-level health behaviors. He's a trained wilderness first responder and volunteers with Summit County Search and Rescue. Following his presentation, Dr. Cambron will have about 10 minutes to take questions. Please use the question and answer button at the bottom of your Zoom window to submit any questions that you have. And with that, Chris, the virtual stage is yours.
Okay, thanks, Philip. So just a quick overview of what we're going to be talking about. I'm going to do a little bit of background on socioeconomic status and health, some of the connections between SCS, smoking, and health. This is mostly from like a 30,000-foot view. And then I'm going to talk about a few specific studies that I've led around developmental trajectories of smoking, smoking cessation processes, and smoking geographies among Utah youth. And we're going to look at SCS differences. And all of those, and like Philip said, it'd be great to do questions at the end. So SCS is it's a multifaceted concept. We see different definitions of it. Usually the center point is somewhere around the combination of education, income, and occupation. And generally, when we see research on the topic, we're most often talking about education and income because those are the easiest. Those are the easiest to scale. We can see high education versus low education, high income versus low income. Occupation is a little more challenging. But really, what we're talking about is some sort of proxy for economic mobility, social status, the resources that people have access to. And these things are so strongly linked to our health outcomes that we call SCS a fundamental cause of health. So one of my favorite quotes about this is from Joe Phelan, who is one of the primary authors of the fundamental cause theory of health. It says that these disparities are very large, very robust, and very well documented. And we can see one clear example I can share with you. College grads live about 12 years longer compared to those without a degree. A 12-year difference in life expectancy. That's substantial for any research frame. Another way we can think about this is that places have an SCS. So we can see this through maps. So we can look at life expectancy across the country. In the dark red, we see life expectancy in the mid-60s. So some of those pockets in different places. And then pockets in the dark blue, that's more in the mid-80s. We can overlay a map of poverty rates and see something very similar. It's not it doesn't map on exactly, but the places in dark red are higher poverty. That tends to map onto the places with lower life expectancy. We could do something similar with a map of educational attainment across the country and see a similar distribution. So what we're typically thinking about is that SCS has this individual level component that we talk about, as well as an area level component. So we're going to look at both of those today. It's also really important to recognize that SES and health are bidirectionally associated. So by this, I mean that low SES populations are more likely to experience chronic diseases such as cardiovascular disease or multiple types of cancer. And that at the onset of a chronic disease, on average, we see an 18% drop in net income, which is also a substantial drop in earnings. Usually that has to do with medical costs, that has to do with lost work, lost productivity, maybe home caregiving responsibilities. So that's what we mean by bidirectionally associated. And when we think about this association, cigarette smoking is a major driver. So that's why we're talking about that today. And that's why it should be one of our primary interests. If we're interested in socioeconomic disparities, we should be interested in smoking. I think we all know by this point that smoking is not good for you. How not good for you is it? I feel like people don't always have a full appreciation of that. So smoking is a known cause of 16 different types of cancer. This is actually from a couple of years ago, that estimate, and it goes up over time, finding more links between cigarette smoking and different types of cancer. Shortens life expectancy by 10 plus years on average. And this is just an estimate from this past year. So thinking about the causes of all premature deaths each year, about 18% of premature death in America is directly caused by cigarette smoking. It's more than 500,000 people. You'll see slightly different estimates around from the high 400,000s to the low 500,000s, because we can't know exactly. But either way, it's a huge number. Here's are some of all the different ways that shows up. One of the important things to note is that smoking causes more deaths each year than alcohol use, illegal drug use, HIV, motor vehicle accidents, and gun-related deaths combined. More than all of those combined. So it is a substantial issue. One brief bit of good news. We don't have a ton of good news in this talk, as we're just describing socioeconomic disparities and how to think about that. Smoking has gone down quite a bit over the last couple decades, from about 42% of adults in America in the mid-60s to about 14% in the late 20-teens. Right now, it's about 12.5%, but that's still 31 million people. So even though this is really an amazing public health success story, there's still a lot of smokers out there. We can see this directly linked to how many people die of cancer. So in these two graphs here, we've got some slight differences for men and women, but we can estimate the amount of deaths that were averted by those substantial drops in smoking that we saw on the last slide. So the red line is kind of what we would expect, an absolute number of cancer deaths. And the blue line that emerges below it is how many have been averted based on those declines in smoking. So the declines are coming from multiple sources: increased treatment, increased cancer screening, more widely available screening. But we can roughly say about 1 million deaths due to cancer have been directly averted from reduced tobacco use. So about 130 lives a day for 20 years, if you want to parse it out like that. The other important thing to think about is these deaths, they don't register for about 40 years. So very few smokers start after the age of 30. The peak age for lung cancer incidence is around age 70. So for example, drops in smoking that we saw in the early 2000s, they're not even going to be measurable in our mortality statistics until at least 2040. And as smoking has gone down over time, we should see increasing reductions in mortality up into the end of this century. Well, like most other things, in this country at least, we have these public health successes, and they're not equally distributed across the population. So we had, looking back at the 60s, in this graph, the bottom line is the highest education folks, and then we step up to lower levels of education. So we can see that there was a gap. There has been a gap between college-educated folks and less than college-educated folks in their smoking rates since the 60s, but this gap has actually gotten wider over time. So as more highly educated people are quitting smoking at substantially more quicker rates, the lower SES folks have not seen the same drops. So when we look at this, and we can do an explicit estimate of that, when we look at this 12-year gap in life expectancy between college grads and non-college grads, cigarette smoking accounts for 34% of that disparity, and the gap is actually widening over time. So I say on this slide here that smoking is expensive. And it's not just that, I don't mean just cigarettes cost money. I mean that SES is related to cigarette smoking, and then which directly contributes to these chronic diseases, premature mortality, and this direct contribution to loss of individual income and societal productivity. So this is kind of it's kind of like a cold set of numbers about this, because we're actually talking about people who are sick and losing their lives, but we can put the numbers on it. And for 2020, we lost about $362 billion in income directly due to smoking, so 1.7% of GDP, and about $74 billion in lost productivity. And that, if you're interested in that topic, this paper from this past year has a lot to say about that. That's actually the low estimate. That's their most conservative estimate. It could be as much as $100 billion, higher than that. So we have this complex process playing out over time, over the life course, or socioeconomic status is related to smoking, which is related to chronic disease, which is related to future SES. And then, of course, we know this bottom line here that previous SES, family SES, that's strongly related to our future SES. So I'm actually only talking about this one little part of this process. I am interested in identifying the mechanisms by which SES is connected to smoking. So one of the ways that we think about that is through this social ecological model. So we can think about behaviors being kind of the center of this idea. And then over time, we have different influences at different points in our lives. We have family, peers, school, work. You can have your neighborhood, your local area, and then different regions, different localities have different public policies. So this is, as much as you can possibly think of the types of social influence that you might have in your life. But we need to consider all these different aspects of these different ecological levels and how they change over time and how they're relevant at different developmental points in our lives. So if you're more familiar with the medical literature, they often refer to these connections between SES and health as meta mechanisms. I'm using the social ecological model here, but they're kind of speaking the same language. And so a lot of this comes from what is fundamental cause theory. So if you're not familiar with that, I'm not going to go into a ton of detail about that. But this is basically the idea that even though our technologies improve, we have public health efforts like the reductions in smoking, there are other mechanisms in society that are going to reproduce disparities, regardless of how things change over time. So a lot of this comes from the work of Bruce Link and Joe Phelan. And one of the prime quotes that I think that describes this, Joe Phelan again says, key resources such as knowledge, money, power, prestige, and beneficial social connections can be used no matter what the risk and protective factors are in a given circumstance, and that these evolve over time. So as our social worlds change, there are mechanisms of power and privilege that reproduce disparities. We could go for a long time just on this theory, but it's a lot of what we talk about in social work, personal environment, and access to resources. So I'm going to speak specifically about two studies that I conducted on the developmental trajectories of smoking. This is one of my favorite quotes on the topic from Olivia Lee, who is a social work professor at USC. And she says, substance use is an inherently developmental phenomenon that often begins during adolescence and evolves across the life course, highlighting the need to identify factors contributing to the emergence and persistence of substance use problems across the life course. So I'm thinking about this emergence and persistence, and we expect that some portion of youth start smoking. We also expect that some portion of adults will keep smoking. In general, as folks age, they tend to age out of substance use. So the kids age into it, they experiment, Some stick with it. Among those who stick with it, adults tend to age out. So we need to look at trajectories of how these things are developing over time. And to do that, to identify the factors contributing to the emergence and the persistence of smoking, we need longitudinal data across many years. So I had the benefit of working with a study that has done just this, started in 1985 in 18 Seattle public elementary schools. 808 of them joined this study, and it's actually still going today. So all these blue dots here along the line, these are the different points where data have been collected. There's actually been a couple since then. We've had a 90% average retention rate over this, which is fantastic. So there's still some of the living sample. So some folks have passed away over the years. Of course, of the living sample, there's some 700 plus who are still involved in their late 30s, early 40s. And a lot of their kids are actually involved in the study now too. So we have multiple generations. It's a really, really amazing data set. And so I'm speaking specifically about two important developmental periods for cigarette smoking and looking at the socioeconomic differences in these areas. So from age 10 to 14, and then from age 30 to 39. And these are two papers that go along with what I'm going to tell you about in the next couple minutes here. A little bit about these sample characteristics. So this is actually a very racially, ethnically diverse sample for the Seattle area at this time, and it was evenly split by sex, gender. We can look at the socioeconomic environments that these kids grew up in. So if you're familiar with Seattle, this is a map of the area, and the darker red dots. So each dot on there is actually where one of these kids in the study lived. So there are 808 dots on there, and the darker red ones are the lower SES communities, and the darker blue ones are the higher SES communities. If you know the Seattle area at all, that map looks exactly like we would expect. And then at age 30, about 26 had a college degree. So this was in 2005, and about the average household income was about 50,000. So that's roughly on par with the United States as a whole. So the goal of these two studies were to examine the extent to which SES helps us understand these developmental trajectories of smoking among both youth and adults. We can put that into a specific research question. So we do expect that there is some general normal trajectory. And I put normal in quotes there is because we have kids experiment with cigarettes, and this is back in the 80s, so that was a lot more prominent than it is now. And then we're expecting that adults try to quit, and they kind of come in and out of smoking, and they eventually quit. Most smoking cessation processes, you don't succeed the first time. So it's something that develops over time, and eventually it sticks. So the questions that I'm asking are, do the indicators of the social ecological model, do these account for the associations between SES and deviations from this normal trajectory of smoking behavior? So we're going to look at whether there's SES differences. Given the title of the talk, you might have guessed that there are SES differences. And then we're going to try and see if these social ecological model factors, so these different levels of how we interact with our friends, our families, our schools, work, is that what's accounting for these SES differences? We can look at just the average rates of smoking in the sample. On the left is from 1985 to 1990, so this is when they're kids. We can see it, as we expect, going up over time. And then from 2005 to 2014, you can see that it's on average dropping over time. One important thing to consider, because this is a longitudinal panel, so they were checked in more often with when they're kids, and then in adulthood, it was either every 3 to 5 years. So there's a lot of things happening in there. So, kids at age 11 might say, oh yeah, I smoked a cigarette in the past month. But at age 12, they might not have, just based on when they connected with that kid. So we have a method that's going to account for that and kind of look at the variability after we say, on average, what's happening with all these people. So I'm going to talk specifically about the youth sample first. So we use an approach called a latent growth curve. And so basically all that says is that on average, we think this is where most of the sample starts. Of these 800 kids, this is where about they're going to start their smoking. And this is the average trajectory of their increase in smoking. After we do that, that's kind of just our best guess for how people are, their developmental trajectories. But that doesn't account for everything. So we've got folks that deviate from that average trajectory, and that's what's left over in this box in the center there. So we've got the trajectories and how they deviate from this average trajectory that we set. So we already saw in the last slide, we know on average is increasing over time. So we basically are trying to understand who are the kids who are increasing smoking faster or earlier or something along those lines. And then we look at, are there any differences based on their socioeconomics or some of these other social ecological factors? And so for socioeconomics, we were able to look at the type of neighborhood they were living in, so the neighborhood poverty levels, and then their residential stability. So were they moving a lot? So it's kind of a sense of, are these folks who are living in more stable households, more stable neighborhoods? Residential stability tends to be strongly associated with, like, so higher poverty neighborhoods tend to be less residentially stable, a lot more influx of people in and out. We can also think about family income. And for each line here, so if it's a solid line, that means that we saw a significant relationship between those factors and smoking trajectories. And if it's a dotted line, we did not see a significant relationship. And then the plus or the minus tells us the direction. So you'd interpret that kids living in higher poverty neighborhoods had steeper smoking trajectories, so they were smoking more. Kids within higher family income households had more shallow smoking trajectories, so they were smoking less or starting later. And we considered all these factors as they changed over time because kids move, so these are all time varying variables. So they move neighborhoods, then they get a different SES associated with that neighborhood. Their family income changes over time. As they reported at each wave, we estimate that. And so then we want to look at some of the specific social ecological factors that we think might be a part of this scenario. I looked at family conflict, family smoking environment, and deviant peers. So all of these are generally considered strong predictors of youth substance use. By family smoking environment, I specifically mean, are people in your household smoking? Do you have a peer that smokes? Are you exposed to a tobacco environment? So are there folks in your household? Do you see it? Do you experience it? So all of these factors were predictive of steeper smoking trajectories. So kids who were starting earlier and smoking more. But our SES factors didn't go away. So these are not the factors that are connecting neighborhood poverty and family income to these steeper smoking trajectories. So that tells us that there's something unique about what's going on with SES, and that there's an area level factor, so this neighborhood level, and then there's an individual level factor, so this family level. So we can also, so I'm going to shift over to the right panel here for 2005 to 2014. So let's see what's happening when these same folks were adults. I'm going to use the exact same approach. I'm going to look at their trajectories of smoking from age 30 to 39, and on average, what is happening, and then what's left over. We want to understand the leftovers or the residuals of what is not accounted for by those average trajectories. We're going to do the same thing. We have more data on SES, well, socio-demographic factors, things that do change over time. So again, neighborhood poverty, whether they obtained a college degree, household income, whether they were married or partnered, and whether they were parents at the time. So again, we see the same effect of neighborhood poverty. As expected, one of the strongest relationships that we always see with smoking is education levels. No direct effect of household income, but we do see folks who were married or partnered were less likely to be smoking. And then we consider some social ecological factors, whether or not your coworkers were smoking, whether or not your partner smokes, and a key maintenance driver of smoking among folks in their 30s often has to do, there's strong links between mental health issues and persistent or elevated smoking. So we accounted for anxiety and depression. All of those things, as expected, were related to folks who were persisting in their smoking longer throughout their 30s. But less expected is that even after accounting for all those factors, we still saw socioeconomic differences. So that is a finding that has not, as far as I understand, it's always hard to say this. As far as I understand, there have not been other studies who've been able to look with this approach to see the persistence of smoking among large samples across a decade of time. So seeing that folks who are living in higher poverty neighborhoods and who have lower education continue to smoke developmentally, I think that's a pretty important find. So from these two studies, we see that among both youth and adults, that SES, multiple indicators of SES were associated with increased smoking above, again, quote unquote, normal trajectories. So what we would expect out of those trajectories. And there was an individual level SES factor and an area level SES factor. So lower SES youth smoked more at younger ages, lower SES adults persisted smoking longer into their 30s. And these associations, they were consistent, even after including these time-varying proxies for these social ecological factors that we think are supposed to connect SES with health behaviors. So how this would work in a statistical sense, we would think that if these social ecological factors were the mechanisms connecting SES and smoking, that when we include those in the model, we wouldn't see any relationships between SES and smoking anymore. But that's not what happened. It was still there. So this tells us that there's additional factors linking SES with smoking behavior. But that's as much as we can say with longitudinal data that is gathered over a number of years. So we want to look at what's happening when folks who are explicitly trying to quit smoking. So we want to look at smoking cessation processes and how SES plays out in that. So like I said before, right now there's about 12.5% of US adults are smoking cigarettes, still 31 million people, so a substantial number. Some recent statistics, about 70% of all smokers want to quit. So 20 plus million people say, yes, I would like to quit smoking. 50% or more than 50% try to quit each year, and less than 5% are successful. And like I said, what typically happens is that it requires multiple attempts for individuals to actually successfully quit. We also have a lot of data that says low SES populations are less successful when trying to quit. So we couldn't see that from the longitudinal studies I just showed you because it's over 10 years and we didn't know if they were trying to quit at each time. We just knew that less people were smoking. But this is a finding that's been replicated by a couple of different studies. But we don't necessarily know why that is happening. Why low SES populations, even when they want to quit and they report that they want to quit, they're less successful. And this has been a driver of the smoking disparities that I discussed before. So these widening disparities by SES, part of it is that folks are starting younger and smoking more. And part of it is that when they try to quit, there are lower successful cessation rates. So understanding the factors that make quitting harder for low SES populations is a good key to reducing disparities. So I was able to look at this using daily life data. So what are the aspects of daily life that you encounter that make it more difficult for you to quit smoking? And I was able to look at 3 different factors. So whether you're spending time around other smokers, whether you're spending time in places where smoking is allowed, and whether cigarettes are readily available to you. And what we look at is how often people lapse. So by the term lapse, I mean that they smoked at all. So these are folks enrolled in a smoking cessation study who are trying to quit. And we expect that people are going to lapse, but usually it takes, it's always hard to say, but it's some number of lapses before we call it a full relapse before individuals return to regular smoking. So I'm just looking at the, on average, how often they are lapsing. We don't specifically know because it takes a lot longer for that to play out, whether they've gone into full relapse. So the question that we're asking is that are lower SES smokers attempting to quit exposed to higher risk social contexts that make quitting more difficult? And this comes from this paper that was published a couple years ago in the Annals of Behavioral Medicine. So to get this daily life data, we use what's called ecological momentary assessments. So basically, you give people smartphones and you ping them randomly throughout the day, so we get a sense of their lived experience. And you say, who are you around? Are you around other people who are smoking? Are you in a place where smoking's allowed? When's the last time you smoked a cigarette? And they just, punch in there what's happening at that point. So when we catch people in real time like that, we get better data because we have less recall bias and error. We get more of what we call ecological validity and generalizability. And you really can't explore these dynamic processes and lived experiences without data like that. So what I'm going to show you is from a smoking cessation study. So folks had to be committed to trying to quit smoking to get in this study. And this is actually conducted quite a few years ago now in the early 2000s in Houston, Texas. So everybody got the same treatment. They all got nicotine patches and counseling sessions. And then they carried a Palm Top computer, which is a very ancient smartphone, for 4 weeks after they said, here's the day I'm going to quit, I'm done. A little bit about the sample. So in general, this was a pretty low income sample. It was a very diverse sample, but overall, more than half the sample had less than $30,000 a year of income. Only 15% were college graduates. In the United States at that time, it's about 30% of people were college graduates. 40% were unemployed, and about 60% were uninsured. So this is pre-ACA, so health insurance was a little bit of a different story back then. So we had 365 participants, and they punched in their smartphone data at 31,800 random ecological momentary assessments across 28 days. So about 87 per person and roughly 3 a day for each one of these folks in the sample. So a lot of data. We can look at these dynamic processes. And what you see, if you just map this out by a couple of these different indicators of SES, so this is just a coarse look at college versus non-college or income above 30,000 versus under 30,000. So we're going to do a little bit better than this in our statistical model. But we just wanted to plot out the data and look, are they spending more time around other smokers? Are they spending more time in places where smoking is allowed? And are cigarettes more available to them? And consistently, we see the same. We see the same across. So those dark blue lines, lower SES, the on top, and the red lines are higher SES folks. So we see these disparities playing out in people's real lives. So to do this, I don't think I have time to really go into all the methodological details of how we get there, but we use what's called a dynamic structural equation model. So I wanted to look at not each individual aspect of SES, but people's experiences overall. So what is their general socioeconomic profile? I can look at, on average, over time, are they spending more time around other smokers? Are they spending more time in places where smoking is allowed? And are cigarettes more available to them? So in each case, as SES went down, all of these factors went up, just like we saw in those last graphs. All these factors are also interrelated among one another, not unexpected. And then when we look at their average smoking lapse over time, we see that all of these factors are connecting SES to smoking lapse through one of these different paths. So lower SES folks were encountering more other smokers, spending more time in places where smoking is allowed, and in turn of both of those, saying, hey, cigarettes are readily available to me. If you've read anything about the smoking cessation literature, when people report cigarettes being available to them, they are much more likely to smoke. There's a whole psychological cueing process that goes on there. So we can see that these are the daily life mechanisms that's connecting lower SES to smoking labs. Basically what I just said, increased daily life exposure. So looking on the daily level, more time spent around other smokers in places where smoking was allowed, and in turn, cigarettes were more readily available to them. So these daily life experiences contribute to the challenges in staying quit long-term among low SES smokers. And unlike our previous studies, these social context factors, these aspects of the social ecological model, they fully accounted for the relationship between SES and smoking lapses. So I was actually kind of surprised to find that all of the differences we see in smoking cessation processes based on SES in this sample were accounted for by where they're spending their time. And so we can think about this, cessation programs can develop and adapt treatments to help low SES smokers navigate these likely encounters with what we call pro-smoking social contexts. So there's actually quite a bit of, there's like a digital tech, a real industry of digital tech to help folks with this that cues them and says, hey, are you in a risky smoking area? And you click the button on your phone and it says yes, and then it's like tells you leave now. But these prompts are actually really helpful for people. So there's some success with those approaches. Okay, so we've looked at this longitudinally, how it develops over years. We've looked at it in daily life, how SES is related to quitting attempts. And as I said earlier, there's really a strong place-based component to SES. And so we can look at how these things are distributed around areas. So this is one of my favorite books about the topic, is the Smoking Geographies. And then just a really great quote from this text. Our overarching assertion is that an in-depth understanding of the relations between smoking and place requires not only an appreciation of the ecologies of spaces, but also attention to the wider social structures that operate to constrain or enable human behavior. I mean, there's a lot going on in that constrain or enable human behavior. So I'm just going to give you a very brief discussion about that and a little bit about what we see specifically in Utah. So as expected, based on fundamental cause theory, based on the distribution of health technology is how Lincoln Phelan described it, that these massive public health successes that have led to reduced tobacco use all across the United States, they have had an unfortunate and unintended consequence, and that what we tend to see is that behaviors that are no longer socially sanctioned. So in general, we can think about cigarette smoking being previously socially sanctioned, and now it's been relegated to a socially governed factor or a socially governed behavior. They tend to get pushed into very specific spaces. And so as a result, we've seen that smoking behaviors and norms are increasingly concentrated in quote unquote socially undesirable spaces that are more likely to exist in low SES areas. So I don't want this to sound like that I'm denigrating these areas. So most of this literature in the sociological literature is written from a kind of a general critique of how capitalist ideologies govern our social interactions. So what they're talking about there is that these socially undesirable places are the places that actually produce the least amount of wealth. So that's kind of what they're talking about. But I don't want to say that there's something specific to that place other than maybe industry is left the area, or there are different economic factors that haven't prospered in that area. These are all choices that we make as a society. So I'm not blaming that area in any way. So like I said, I've looked at longitudinal panel data across years, intensive longitudinal data across weeks among these community samples. But I really want to understand, and these are for understanding processes that unfold over different timescales, but I really want to use area level data to examine features of places and the distribution of different features across multiple places. So this is actually a map of the Salt Lake area. This is from that Opportunity Insights that some of the social epidemiologists at Harvard put out, and it maps the different income concentration around Salt Lake. So Utah youth, they smoke at the lowest rates among the country. I think we all know that. But these aggregate statistics, they tend to hide disparities. So the goal of this project is to examine the geographic distribution of smoking behaviors and norms across Utah youth. And I'm going to tell you a little bit more about those norms in a second here. And then we want to see, does SES help us understand the distribution of these behaviors and norms? The overall goal is to be able to look at this location-specific information, go to communities and say, hey, you've got some relatively elevated rates of these things that we know lead to smoking. We know that as long as you can catch smoking early on in life, you have a better chance of not developing multiple chronic diseases, multiple cancers. So we can give this information to communities to inform their prevention and health promotion efforts. So one of the first papers, this was just recently published, looking at this as a state level data. So these data come from the Department of Health. It's called a SHARP survey. You might have heard about that previously. It's a state representative sample of Utah youth from grades 6, 8, 10, and 12. About every 2 years, it's collected. It's got demographic data, health behavior data. It's also geocoded by zip code, which is really important for my purposes. So the approach I use here is called a generalized estimating equation. So we can look at socioeconomic differences in cigarette and e-cigarette use, family smoking norms, and neighborhood smoking norms. And these are data from 2019. So the 2021 sample is not, the data aren't as good because they had some data collection issues from COVID, obviously. But so we've got about 80,000 kids in this sample. And then we can cluster it by neighborhood, look at how it's, account for the school district aspects of it, and then we can weight it to reflect the population characteristics. Again, I love the maps, I love the pictures. So I was plotting out here across the state. In the darker colors is where we have on the far left, higher neighborhood poverty scores. In the darker colors in the center panel, we have where there's higher levels of tobacco use in the home. And in the far right, we have where there's a higher percentage of kids using both cigarettes and e-cigarettes. So that's kind of a longer conversation about why I included both of those, but e-cigarettes are definitely less harmful than cigarettes, but we're seeing pretty strong identification that e-cigarette use leads to cigarette use later in life. And so I looked at all these factors, whether there are differences at the individual level SES and at the area level SES. Excuse me. So I looked at differences by household education and differences by neighborhood poverty. And so like the quick look at this, these TIE fighter looking things, if you're a Star Wars fan, the dot in the middle is an estimate, and the bar and the wings, those are the confidence intervals. So for the factors underneath household education, we would interpret that since all these numbers are below 1 and all of their confidence intervals are below 1, we would say that there are significant differences as household education goes up. Kids were less likely to use cigarettes. They're less likely to use both cigarettes and e-cigarettes. They're less likely to report tobacco use in their home, cigarette smoking in their home, e-cigarette use in their home. And then they're less likely to report neighborhood pro-cigarette norms, so in their local areas. On the right panel, we see neighborhood poverty, and all of these are above 1 for the estimates. So there's some indication that kids living in higher poverty neighborhoods are more likely to use cigarettes, more likely to report dual cigarette, e-cigarette use, more likely to report tobacco use in their home, cigarettes in their home, e-cigarette use in their home, and more likely to report pro-cigarette norms in their neighborhoods. Some of those confidence intervals do cross that dotted line, which mean that even though we see a relationship, it might not be as generalizable as the other factors. So that's the quick look at what's happening in Utah. So youth in Utah living in households with higher levels of education were less likely to smoke. They're exposed to more restrictive tobacco norms, both in their family and in their neighborhoods. And youth living in higher poverty neighborhoods were more likely to smoke and are exposed to both more permissive norms in both their household and in their neighborhood. So our next step with this is that we're going to take 7 waves of data from the SHARP survey, so 2009 to 2021, and we're going to do these fancy spatial temporal models. So I've got some folks in geography who are going to help me with this, and this is kind of how you do disease mapping. So we're going to be able to identify hotspot areas for where risky behaviors and norms are emerging, and that will hopefully be valuable info for these communities. So just a quick overall summary. I think I'm running out of time here. You probably already know this. Cigarette smoking causes cancer, shortens life. It is a primary driver of all health, SES-related health disparities. So about 34% of SES-related health disparities are accounted for directly by cigarette smoking. That is a massive amount in how we consider these behavioral factors. So, for example, for a comparison, alcohol use and drug overdose account for about 3% of SES-related health disparities in mortality. Cigarette smoking, 34%. It is for social workers interested in increasing health equity, cigarette smoking is where the rubber hits the road. Just a quick recap, even after accounting for all these social ecological factors that we thought would connect SES and smoking, we do see that lower SES youth are more likely to start smoking than their peers, and lower SES adults are more likely to keep smoking. During a quit attempt, lower SES smokers had greater difficulty quitting, in part due to their increased exposure to these pro-smoking social contexts. And then for this last study I just showed you, Utah youth living in lower SES households and neighborhoods were more likely to smoke and exposed to more permissive tobacco norms. So this tells us that there's a lot of factors that contribute to the growing SES smoking disparities, and there's a lot of work to do in this area. I don't have time to talk too much about that, but there are people working on the community-based prevention resources. So here's a couple of things that are going on, both in Utah and nationally. These are some summary articles of what's been going on. And I think I'm about out of time. I just want to say there's a number of funders who are super helpful with this, and a number of collaborators across both the University of Washington and here at the University of Utah. And now we can take any questions. Just made it. So I see some questions. Has the increased popularity of e-cigarettes changed smoking behaviors? Does that differ for different SES groups? That question is undecided as of yet. So there have only been a couple papers, which is one of the ones I just showed you, looking at socioeconomic disparities in e-cigarettes. And as they become more popular, the socioeconomic distribution of them is changing. So we don't have a good answer to that yet, but it looks like there are SES differences. When the SES makeup of a neighborhood changes due to things like gentrification, do smoking behaviors in that physical space environment shift? That is also a very difficult question to answer. The general sense is probably. And that is typically, it could be a number of factors, but it's usually more highly educated folks moving into that neighborhood who by massive amounts smoke less. And and those are the folks who tend to have power and privilege, and they set up smoking bans which I agree with smoking bans. They set up smoking bans in public places, in bars and restaurants. So typically, yes, the smoking behaviors in that physical space environment shift. Could you please share a few intervention ideas for youth living in high poverty areas, especially those living in homes where others who smoke? If we had those, I would absolutely share those. So this is one of my absolute goals, is to help develop interventions that are specific to reducing socioeconomic disparities. Health promotion programs, a recent meta-analysis showed that health promotion programs can do this, but they often don't focus on that. So we really need to take these prevention approaches and specifically apply them to different socioeconomic contexts. Because like any health promotion approach we use, folks with less resources tend to have lower uptake. I think that's all the questions. Those are good questions.
Thanks, Chris. Any last questions from the audience? Looks like there is one more in chat there.
One more came up about data looking at the U to begin tobacco-free campus. So I have not seen any data on that as of yet, but I'm sure that's forthcoming.
Chris, there's also one in the chat that says, what can schools do to help change the permissive messaging students are getting at home and in the surrounding community?
So that is also a very challenging question. The Communities that Care program, I'd encourage you to look into them. They have a substantial norm-based program that has kind of engages local stakeholders around helping to modify community level norms. So I think that would be the best place to look for that information. You can go to communitiesthatcare.net. They're pretty easy to find, and they're active in Utah as well.
It looks like we have another in the Q&A about product placement.
Yeah. Oh, that's a great question. So there are folks looking at like vaping. So that's a really appropriate question, because I didn't talk about that, but one of the other mechanisms that connects SES to smoking is the placement of tobacco shops. So you can go downtown and get at Salt Lake and go to Harmon's and get cigarettes, but you got to like really look to find them. If you go to like lower SES communities in Utah, I mean, you have prominently displayed tobacco shops. So there are some great folks at the Pacific Research and Education Center. I'm not remembering the exact title, but they do mapping of tobacco shop and alcohol shop placement, and how that influences youth norms and perceptions, and how that influences community level rates. But the real way to think about this, because kids these days have access to lots of things via smartphone, is the digital advertising coming in. So there are some folks working on that. As of now, I haven't seen any definitive studies as of yet whether there is an influence on behavior, but most of our theories would say there probably is some influence.
Thanks, Chris. That a really great, fascinating presentation. So I want to thank you for your time today, for your scholarship on an incredibly important issue. I thank you to everyone who joined us live today, as well as those of you who are going to watch this recording later on. Always a special thank you to the development and PR team for the many efforts that they put in to pulling off these events that we have. The College of Social Work is committed to taking the evidence that we generate through research and from our labs, not only to future social workers sitting in classrooms, but also out into the community and to practitioners beyond our state lines. We hope that you will continue to join us throughout the years we share our work and explore evidence-based solutions to society's various challenges. Please check out our website. You can find details about all of our events there. And again, thank you so much for being a part of this event. Thank you, Dr. Cambron. Thank you to the audience, and thank you to the staff support from the College of Social Work. Have a great afternoon.
Thanks, everybody.